Hello, everyone, and thank you for joining us today. My name is Susanna Titendrun, and I'm a Global Resources Manager here at UICC. I would like to welcome you to this special focus dialogue on prognosis in cancer, staging, prognostic factors, and outcomes. Before we start, I would like to remind everyone of a few housekeeping rules. Please mute your microphone when you're not talking, leave your camera on if your connection allows, and open the chat box to make any questions to the panelists. You can also ask your questions by raising your hand in the Q&A section of this discussion. Today's virtual dialogue will start with a short introduction, followed by presentations by our panelists. Then there will be a moderated panel discussion and a time for question and answers with participants, followed by a short summary. And now I'll hand over to Dr. Mary Gospodarovich, UICC TNM Project Co-Chair and UICC Past President, who will chair today's virtual dialogue. Mary, the floor is yours.
Thank you, Susanna. Thank you and welcome everybody. Good morning, good afternoon, good evening, wherever you are. It is my pleasure to chair this session. The UICC has been engaged in the project on cancer staging and eventually prognostic factors and prognosis for many years. And the objectives of our virtual conversation and consultation today is to agree and understand the value of cancer staging, discuss the issues surrounding prognosis and prognostic factors in cancer, and discuss the use of prognostic factor staging, prognosis and cancer control planning in clinical practice and in research. And I am joined by a number of colleagues who have been deeply involved in the conversations and the publication and research on the subject. We all know that we deal with prognostication and prognosis in cancer every day in our clinical practice, and understanding that the prognostication has changed from very informal a process to what has become a sophisticated process of calculation of outcomes for a distinct endpoint in cancer. And when we talk about prognostic factors, we talk about any disease or patient or environmental characteristic that would affect the outcome in cancer patient or patient population. The speakers today, can I have next slides, are Dr. Jim Briley, the co-chair of the UICC TNM and Prognostic Factors Project. Jim is a radiation oncologist at the Princess Margaret Cancer Center and has been involved in cancer staging and cancer registry work at our hospital and collaborating with Canadian Cancer Registry and with AJCC for many years. And he will talk to us about cancer staging. He will be followed by Brian O'Sullivan, who will talk about prognosis and prognostic factors. He is a radiation oncologist at Princess Margaret Cancer Center in Toronto, chair of the UICC Prognostic Factors Subcommittee, and also a professor at University of Montreal at the present time. He will be followed by Brian Bruce, who will talk about pathology and the crucial importance of pathologic classification and pathology in cancer staging and prognosis. Brian is a pathologist. He works in Public Health England, and he's a member of the TNM Project Core Committee. And finally, Dr. Elizabeth Van Aken, also the member of TNM Project Core Committee, a radiation oncologist who is now cancer epidemiologist and works for Belgium Cancer Registry. Lisbeth also adjudicates the TNM help desk for the UICC project and has great experience with cancer registries, cancer registration, and the role of staging and prognostic factors in cancer registration. The format today will be that we will ask each speaker to just have a couple of slides and talk to you about 4 to 5 minutes about their subject. And then we will have a quick conversation between the panelists and leave probably around 15 minutes towards the end for your questions and discussion. So there'll be opportunities to ask questions. Please feel free to put your questions in the chat, but we will open the forum for just the questions in the last 15 minutes, and then we'll wrap up. So to start with, I'll hand over the microphone to Jim Briley. Jim, over to you.
Thank you, Mary. Susanna, can I have my first slide? Thank you. So as clinicians, but also cancer registrars, there are 3 fundamental things we want to know about any patient and their cancer. What's the site of origin of the cancer? Is it a lung cancer? Is it a breast cancer? What are the histological, biological characteristics of that cancer? Is it if it's a lung cancer, is it a squamous cell carcinoma, an adenocarcinoma, or a small cell carcinoma? And if it's a breast cancer, what's the grade? What are the receptor status, for instance? But the other thing we all want to know is what's the anatomical extent of disease? Anatomical extent of disease, along with, say, age and performance status, are vitally important prognostic factors and needed to know for clinical care, for assessing the prognosis of the patient, for determining the appropriate treatment, but also important in cancer control and surveillance. And it's also important that we all speak the same language. We're all talking about the same thing. We don't talk about Duke stage in colorectal cancer, for instance. Susanna, can you go to the next slide, please? So as I said, it's vital information for determining the prognosis of an individual patient, and also what's the appropriate treatment for that patient. But we also use it all the time in cancer research. One of the fundamental questions for any clinical trial is what's the stage of the patient, and that determines the eligibility for that clinical trial. We also obviously use it in cancer surveillance. We want to assess the burden of disease. In prostate cancer, you may have 2 areas where the incidence is similar, but in one area it's mainly early stage disease, and in another area maybe advanced stage disease. And obviously this has a very different needs for that population when it comes to cancer control and health service provisions. And also used for other things such as assessment of success of screening. You introduce a screening program, you want to see a difference in distribution of that stage with increasing number of early stage cancers, as well as obviously a reduction in the incidence of that cancer. But we also know that there's challenges, the needs of the individual clinician and cancer surveillance community is different. The physician and the patient want most up-to-date information and science available, whilst the cancer surveillance community, for comparison's sake, wants to have a degree of stability. So if you're looking at screening, for instance, you know your stage 1 and the stage 4, which are changing because of the success of the screening, not because of the difference in definitions. But at the same time, we know that things are changing. The last edition, for instance, of TNM, change in nasopharynx because of the success of treatment with IMRT led to changes in the T category because of the prognosis is so much better. And we also know that there's changes in tumors and biology, again, from the head and neck incidence in oropharyngeal cancer, we know that HPV tumors behave differently from HPV negative oropharyngeal tumors, and the staging system had to be changed. So there's this consistent dialogue between the two needs, between the individual patient and physician and the cancer community, surveillance community, when it comes to cancer stage. So I will stop at this point and hand over to my colleague, Dr. Brian O'Sullivan.
Brian, you're muted.
Sorry, I was obeying the rules and I forgot. Sorry. So what I'd like to show in the next few minutes is the complicated nature of prognosis for our patients with cancer, and those of us who follow patients and register patients, which I think is a very important part of today's discussion. So this is a very complicated multidimensional paradigm which we use to understand how cancer responds to treatment and how it behaves and how our patients fare. But it's a very detailed, lengthy, dynamic, and variable process that goes on, obviously, for all of a patient's life and all of groups of patients as well. And I want to emphasize the second bullet, that you cannot measure prognosis without understanding or specifying an outcome. So if you don't have the outcome, you really just have a general idea of what's happening. You need to be quite specific if you're going to put some scientific aspect to this area. And we also need to appreciate the setting of the patient, which I will address momentarily in relation to the outcomes and the treatments, as well as prognostic factors. Now, the potential outcomes are very variable and are shown on the right-hand panel here, just as a set of examples of common outcomes that are used, and I will comment about them in a moment. But I would also like to point out that we don't have a universal classification system. There are a number of systems available. For example, the UICC has one which is structured along the lines of what is a relevant prognostic factor, for example, for treatment, or additional factors maybe for clinical trials, or developing in the research environment. And we tend to divide these into what affects the tumor, what affects the patient, and what affects the environment, which we will comment on as well during the morning. Now, it's a very unappreciated area, and there's a tendency to try to produce or introduce factors directly into the TNM. So that might be something Jim may want to comment about as well subsequently, as to whether the TNM has to bear the burden of all classification because it's designed as an anatomic system, not necessarily to carry everything else. So that is an important aspect, and it tends to go on all the time because there's no other obvious classification system. And then there's a very popular idea, which is to look at risk assessment using nomograms, which are nice for talking to patients about. Whether or not they're validated or not is another issue, but you can tell taking into account a number of factors, what the likely outcome is maybe for an individual patient, but they're not that useful for group comparisons. So they can't really replace a classification system. So on the right-hand panel, you'll see a number of outcomes, which obviously has survival and various composites like progression-free survival, but these do not tell the whole story of the patient with cancer. It doesn't address local regional control, distant control, or organ preservation. It doesn't address a response to treatment, which I've shown examples there. And response is a double-edged sword because you don't know what the response is until you give the treatment. So don't try to describe it as a baseline factor. And that's one of the problems with retrospective studies, where people will try to use the response and pretend they had it at the start, which they didn't. So it can be useful though, because it can make you, give you the opportunity to modify treatment subsequently, depending on what happens. And then there's a large area, which is very important, about patient-reported outcomes, which include function, quality of life, pain and symptom management, psychosocial aspects, as well as value-based outcomes such as cost effectiveness and return to work. Can I just have the next slide, Susanna? So one of the other things that we have to recognize is that cancer evolves over time, and also the patients evolve over time. So the disease does change anatomically if tumor spreads or grows, and biologically may transform as well. But also the situation may happen in a different way for different patients. Response to an earlier intervention may make you change the management that happens subsequently, including something as simple as surviving a difficult operation. That's a good thing, obviously, compared to if you didn't manage to achieve that. And then the tolerance of the patient can change with intensity and repeat management, and the fact that maybe some of the treatments may not be possible in a subsequent event because they've already been used previously. And as patients age and develop comorbidity in chronic indolent disease, you also have to take that into account as well, and it affects the prognosis. There are also some specific elements to be aware of, like when should you measure prognosis and what are the circumstances? Is it at diagnosis only or at recurrence? Or when after you diagnose, or when after the patient has recurrence? During the ongoing aspect, is it at 6 months, a year? Should you be still measuring these? So these have not really been defined properly at this time. And then there's also the intervention that may take place. So an example of this would be a HER2 positive breast cancer patient with an adverse prognosis, but if you give Herceptin, it changes that. A patient with resection margins that are positive in a disease, that is not the same as a patient who has resection margin positive, but has received radiotherapy, for example, because it can ameliorate the adverse feature. And I try to capture these in this framework that we describe as the management scenario on the right-hand panel, where we take the tumor, the patient, and the environment having the main prognostic factors, but also recognize the intervention that can happen. For example, I used radiotherapy or the use of Herceptin as an example a moment ago, and also looking at what outcome. Is it survival? Is it local control? Is it pain management? Is it organ preservation? These all are going to have different dimensions in the whole aspect of what you measure as prognosis. So this is a very complicated area, relatively exciting area, in fact, but also has not really been addressed fully to be able to, for example, capture the data in our registries. So I'm going to hand over now to Brian Roos, my colleague in pathology on the TNM committee.
Hi. I was asked to talk about cancer pathology, which is obviously potentially an enormous subject that you can cover in 5 minutes. So I thought I'd pick out a few challenging topics and almost approach the more philosophical aspects of cancer pathology. So you might think at first glance that defining what cancer is a fairly simple task, but I wanted to highlight that isn't actually the case. So the pictures we have on the right there is the WHO classification of tumours, or the Blue Book series as it's known, which is assembled by experts from around the world to agree on the actual classification of tumours. But what is cancer has may change the definition on that. So how to define cancer is quite complex. So you might think that simple things that you obviously associate with cancer might define a cancer. So a tumour metastasizing would define a cancer. But in fact, we do have some entities that are known to metastasize that aren't considered to be cancer, such as benign metastasizing leiomyoma. Or you might think that invasion of adjacent structures might define something to be cancer. And again, there are examples such as meningioma, where the meningioma can invade the skull, and that isn't considered to be a malignant feature, and it's still considered to be a benign tumour. So even common concepts of what we define as cancer can be quite challenging. The list of tumour entities on the left are all entities that appear in the WHO classification of tumours that in the last maybe 10 years or so, we have changed their definition as to what type of tumour they are. So we classified tumours broadly into being benign, uncertain behaviour, malignant, or what we call in situ, which is a pre-malignant stage, state. You can see all that list of entities there. They've all moved from one of those categories to another over the last 10 years as our biology and understanding of these tumours has changed. So if I could have the next slide, please. So how do we tell if a tumour is malignant? So, so broadly speaking, stage is actually working. You might think this is sort of working backwards, but actually, a tumour that has spread either in local extent or involving nodes or distant metastases will clearly be a strong indicator that a tumour is likely to be malignant. So that's an obvious feature. But more generally, we work with what we call morphology. And morphology is the pathologist looking down the microscope and looking at the cells involved in the tumour and identifying features within those. So if a tumour hasn't spread, that doesn't necessarily mean it is not a malignant tumour. So it may just mean that it's been excised at a point in time before it had spread. So our definitions on malignancy don't require actual spread of tumour. So how do we identify what features that would indicate a tumour might be malignant? So it varies from tumour type to tumour type, but the sorts of things we look for are things like pleomorphism, which is variable shape and size of cells, mitoses, so which is a particular nuclear feature that we see when cells are dividing frequently, and necrosis, so tumours will often end up with areas of insufficient blood supply and so on as they grow, and so it can result in necrosis. They will destroy surrounding tissues or invade surrounding tissues as they grow, and so these are all features that we look for, and features and as well as large anatomical structures. We look for involvement of smaller anatomical structures such as nerves and blood vessel involvement and so on as well. And so all these features go into forming our classification of tumours that I talked about on the previous slide. One of the things that is increasingly influencing our classification of tumours and our understanding of whether a tumour is malignant or not is our molecular features. So things that can't necessarily be seen with the light microscope, but can be tested in other ways. And these might identify particular signatures of the tumour that may be associated with particular outcomes and prognosis. So the picture on the right is of a next generation sequencing machine that will will now very rapidly analyze. This one will analyze 50 different genes in one go. So the pathologists have access to much more detailed molecular data on tumours than were previously. So why are these features of the tumours important? So beyond determining whether or not the tumour is malignant, these morphological features will have influence in determining prognosis. So the tumour type will have a correlation with prognosis. Grade will have a correlation with prognosis. So grade is an interesting concept. It's not something which is, you could argue, is inherent to tumours. It's something that we assign. So and is often sort of worked backwards, if you like, in that what we look for in devising a grading system is tumours of the same type, and we're looking for features that correspond with prognosis. So which tumours correlate, which features correlate with a tumour having a poor prognostic outcome to those having a good prognostic outcome, and those features are combined in grade. Often things like the pleomorphism and mitotic activity, etc. And sometimes there'll be features which aren't incorporated into a particular grading system. They're also may correlate with prognosis. So some grading systems won't include mitoses, for example, but that may have an influence on prognosis for that tumour as well. Also, molecular features will have an influence on prognosis, and some of those may be things like I've listed ER and HER2 there, which are have an influence on prognosis in relation to treatment response. So, so again, the influence on prognosis is partly dependent on treatment choices that are being made, as Brian previously described. As we go forward, the increasing use of molecular data proposes challenges for classification systems, in that clearly different parts of the world have different access to molecular data. So whereas most parts of the world do have access to some level of pathology involving light microscopes, access to molecular data is much more challenging. So a lot of work is going on to try not to create a sort of a two-tier system of classification, where if molecular data isn't available, what morphological features would correspond with that molecular data. And if we could have a look at the next slide, please. This was an example where on the left, so these are two papers from the same year. The one on the left was looking at high-grade endometrial cancers and looking at pathologists' ability to differentiate between the different types of high-grade endometrial cancers using morphology or the light microscope. And they found that actually even amongst the experts of the world, the intra-observer reproducibility to making those diagnoses was very poor. And that if you ask different experts what type of tumor it was, you'd get different answers. The paper on the right is taking endometrial cancers, and rather than looking at them morphologically, it's doing a series of in this case 3 or 4 different molecular tests, and categorize them according to the molecular tests. And the picture at the top on the right is showing that stratification of those tumors using that molecular test, so ignoring what the morphological appearances are and just going by the molecular data. And the graph at the bottom is showing how progression-free survival is affected by those different morphological, those different molecular characteristics. And you can see in this circumstance that the molecular characteristics are a very good predictor of progression-free survival. And so we're potentially moving to an era in some areas where the molecular data is much better predictor of tumor type, of prognosis, and therefore perhaps is a better way of classifying the tumors than the morphological features. And so, which will cause all sorts of interesting challenges going forward for comparative data across the world. And that's the end. I'll now hand over to Elizabeth.
Thank you, Brian. Good day to all of you. Cancer registries have a unique position. They have the advantage of being population-based, which means that data of all patients should be included, from the very young till the oldest one, treated in all types of hospitals, and also facing different access to clinical care all over the world. It is clear that cancer registries see their role more and more extended in cancer control activities. And by cancer control, we mean all actions taken to reduce the frequency and especially also the impact of cancer. And this really goes from primary prevention and screening until death and all factors in between, like diagnosis, treatment, rehabilitation, and palliative care. Cancer registries, they're also moving from a more reporting role and descriptive reporting to more outcome-related aspects. But this implies something very important. This implies really a growing need for variables to be collected, besides the more classic ones like dates, tumor localization, histology, morphology, towards more prognostic factors, certainly including stage, but not only stage, also some specific patient, tumor, and environmental related data. Susanna, could I please have the following slide, please? And why is that? It is because we would like to explain differences and disparities between populations, regions, countries. It is therefore that we really need, as a first step, stage at diagnosis, because we would like to recognize regions with more early diagnosis versus late or metastatic disease. And this would really help us to analyze also survival by stage. It is very well known from previous articles and evidence that the distribution of the stages can be very different between populations, like Jim also explained in the first 5 minutes. And the differences between the populations are maybe explaining or indicating different access or no access to care, existence or non-existence of screening programs and early diagnosis or equipment available to have early diagnosis, or even primary prevention campaigns that are really well focused. And we all know that there will be a different adherence to diagnostic as well as treatment guidelines. So we are really aware of the challenges that we have to overcome when collecting more data, stage data and other prognostic factors. Different systems are used, versions, editions, so comparability of data is really an issue. And cancer registries can choose to take a first basic level, for example, going for stage from essential TNM to a more detailed system, depending on the resources. Data must be valid. We all agree on that. And we also maybe encourage collaborations, strong collaborations between physicians and cancer registry people, cancer registry clerks, for example, because they can help to improve the quality of the data. We also agree on the fact that data need to be relevant. So timeliness should be high on the agenda of cancer registries, because data of years ago are less valuable than more recent data. It is not only the timeliness that is important, but also accessibility of the data, to do something with the data and to show differences and to try to explain what could be done. Data must be complete. We really have to avoid in cancer registration, we have to avoid selection bias, because this is not a clinical trial. This is really real world data and trying to give a reliable image of the population. And last but not least, of course, the resources. We are aware that resources are a major concern of the cancer registry. So there is always a need to convince the authorities of the need to have a good established cancer registry, and that has time and, let's say, resources to collect something more than only reporting on incidents. And we are really convinced that all the efforts could result in cancer registries, and there are already a lot of cancer registries who have invested a lot and are able to show very nice things, but it would enable us to evaluate also the measures that are taken and to assess also specific needs of population, indicate weaker points, and this could ultimately improve the outcome for all our cancer patients all over the world. Thank you. Over to you, Mary.
Yeah, thank you, Lisbeth. Thanks. Please put questions in the chat if you want to know more, but I was just going to ask Jim. Jim, you said that you should assign the stage at diagnosis. Can you maybe expand a little bit of why is it important to assign the stage of diagnosis and not change it every time the patient has a recurrence?
Well, I think it goes somewhat into Dr. O'Sullivan-Bryan's discussion of scenario, in that stage at diagnosis is really the only sort of stable and consistent scenario. And if you're collecting stage and you want to compare like with like across jurisdictions, you need to stick to one stage and stick to the stage of diagnosis. If you start looking at calling the extent of disease on recurrence stage, then that's affected by all sorts of things that Brian discussed, such as treatment. And so it's important that you're all talking about the same thing. And if all extent of disease is then called stage, then you really have a Babel's tower of stage, and nobody really knows what they're talking about. So I think it's important we have a consistent time point and consistency at the beginning of the treatment paradigm and the path that the patient is going along. So it's important that we record stage at diagnosis and call that stage. If you're recording extent of disease, then you need to identify that that is the stage at diagnosis.
Thanks, Brian O'Sullivan. Do you want to add to that?
Unmute. Sorry, I was muted. Sorry. No, I would agree with Jim. The big problem is the dynamic aspect that I mentioned of cancer. It changes as time goes by. It changes depending on what has already happened previously and the nature of any recurrence that may manifest. And you cannot start claiming a patient has a set of variables that don't actually apply if you're comparing them at baseline. It just doesn't make any sense. You need to have it structured. Now, there are some options for doing it later, but you need to be very specific about those for describing patients that may have recurrent metastatic disease and so forth. But the stable aspect of TNM is to measure it right at the time the patient is diagnosed, and not after they've had some form of induction or neoadjuvant treatment and so forth, because that means that you've now split the group into two different types of patients, those who responded and those who didn't respond. And you can't expect them to behave the same way in terms of their ultimate outcome. So those who respond have generally a better prognosis, and you can't start describing them at that point. They must be described at the very outset to understand the value of an intervention or the comparison of the groups across different jurisdictions.
You also, Brian, talked about various kinds of prognostic factors. So we understand the extent of disease or stage. We use it every day in clinical practice. Pathology is a cornerstone of cancer classification, and Brian Russ talked about it, and Elizabeth talked about classification. But Brian, can you talk a little bit more about the environment? Or what do you mean by environment and other prognostic factors, and how do they affect the outcomes, and why are they important?
Yeah, well, this is a very important aspect, which is often underemphasized in much of the literature and in discussion. It's almost as if people regard this as, you know, I can't deal with that problem. That's someone else's difficulty. If you can't have the right treatment, or you can't get to the treatment on time, that's not my problem. That would be the kind of attitude of some groups. So this is an area that is very underemphasized, and there are a great number of factors that come into this. It's a huge scope in its own right, but it extends from everybody from the physician, the healthcare system, and society, and the various subdivisions of that, going on into treatment and education and quality of care, and all of those are very complicated, and they all can influence the outcome of patients with cancer. What's very important to recognize, though, is that ironically, while they may seem mundane and they may seem so self-obvious, and we don't try to address them because they're not, as I said, my problem or your problem, whatever, but what is quite important is the concept that these actually are the most modifiable factors that exist. So, you know, you can't really change the stage of the disease, and you can't change the nature of the pathology, and you can't change even the treatment you're giving. But you can change the environment into better resource allocation, better education, have accreditation of programs so that things are done in a proper way that's agreed and gives the highest quality, and that you have quality assurance on the treatments that are delivered. So you make sure that it's done properly and follows appropriate guidelines and have oversight to make sure those things happen. These are simple measures, but they actually do affect, and there's plenty of evidence actually in the literature that these are very important. They can override the influence of many treatments or even a full stage stratum of prognosis if you don't actually give the treatment properly, or if you don't give the treatment in a timely manner, or obviously if you don't have access to the treatment. So I could go on forever on this one, Mary, if you want me to comment further. There's an awful lot in this whole area to do with, you know, distance from the cancer center and so forth. Critical mass of patients that are seen in a center, especially for rare diseases, whether people should be doing things that they're not, they don't have the experience to address. All of those kind of aspects are very important, and there are many elements to do with educating physicians, making sure that they're up to speed, having proper continual medical education programs, and so forth. So, and then it also affects society and what is the attitude in terms of making sure people have got access, making sure that they're not dependent on insurance systems that don't necessarily cover the whole society. All of these aspects are very important in terms of what happens to patients when they're diagnosed with cancer.
Thanks, Brian. Brian, Ruth, there's a tendency to change staging classifications, and you know there's tendency of literature in literature of people developing their own, and I just want you to comment because you're involved in the pathological classification, and there is I think consensus that WHO is the global standard. Can you comment a little bit about why do we need to have a universal staging system?
Yep. So I think universal classification system. So both classification of tumors and staging is incredibly important. We obviously, we all want to improve outcomes for patients, and the only way that we can move forward that as a whole globe is by sharing data and comparing data, and so that if one person is talking about tumor X of stage Y in one jurisdiction, that means exactly the same to another person in another jurisdiction. On the classification of tumors side, the WHO classification led by Ian Cree has done a great job in becoming that established standard, so that pathologists around the world all refer to that classification system, and that isn't that might sound like an easy task. It's just writing something down, but a classification system is a bit like slicing a cake. There is no correct one way to do it. You can do it in lots of different ways, but this is getting everyone around the world to agree, to slice that cake in exactly the same way. And that it's a difficult task. It involves consensus and consulting with a wide number of experts, using evidence-based where there is evidence, but ultimately having the same classification system and the same staging system across the world is very important. And there's increased number of increased number of movements of trying to establish the same reporting patterns for pathologists as well. So there's a international collaboration for cancer reporting, which is aiming to sort of standardize how pathologists report cancers and to make sure that the same features are all mentioned. And again, all referring to the TNM staging system where applicable, so that the important parameters for staging can be collected at the same time.
Great, thank you. So we have a question from the audience, which is very timely because, Elizabeth, I was going to ask you about the role of cancer registries, and The question in the chat says, please elaborate about the importance of having cancer registry data presented in layperson language and be open to public to play a role in advocacy for cancer control. So two concepts there. First of all, to understand the registry data and have the registry data. And the second is having it accessible. And I know that when we talk about cancer registry data, we very often frustrated about, you know, even when you do research about the sort of access to timely and contemporary registry data. So Lisbeth, I'll give the microphone to you if you unmute yourself. And I see Marion Pinero's also there. If she wants to add later, that will be great. Over to you, Lisbeth.
Thank you. And I'm very grateful that Marion is here to complement my answer, certainly. Cancer registries, they do have an important role in public health. So that means that we have to translate the information that is available in a cancer registry to the general public. Of course, we need to participate in scientific research. That is also very important. But the first thing is to be comprehensive and clear for authorities and for the general public. So I think it's maybe a challenge to do so. And I agree with you that we have to be able to present the data in a very okay way. And I think that this is possible. And I maybe would like to invite you to consult some websites also from different cancer registries that you can start from the IARC website, for example, and to have an insight on the data that are communicated. That's the first thing. And the second thing, on accessibility of data, I think if we want to monitor data, we can't do the work all alone. So data should be accessible also for external, let's say, research, internal research at the cancer registry also, but data should be accessible. That means that we have to put them in a very comprehensive way together to have information, because data altogether are not representing yet information. So that is a challenge for the cancer registries. We have to monitor the effects of, for example, a cancer plan and see if specific initiatives really will lead to improvements. For example, like we heard the example also from Jim before, if we have a colorectal cancer screening, do we really reduce the metastatic disease? And I think this is really very good to have the interaction with the general public and to put the accents on what the cancer registry can do. And I think that they can become, with your question and the two things mixed up in this, that the role of the cancer registry can become a pivotal one. And I think that too little cancer registries maybe at this moment have that role, but I think there is really hope to do so in the future.
Marion, do you want to add?
Thank you, and good morning or afternoon to all. Thank you, Mary, and thank you, Susanna and Lisbeth. Yes, I think that it is crucial to link the cycle of the data production, that is like the registry role, with the cycle that the public, that the health decision makers have in public health. And there is a big gap to how to disseminate and communicate better so that the data are used. I mean, a surveillance system like a registry doesn't make any sense if we don't use the data. And definitely in research is one of the uses, but the way we communicate the registry data can and has evolved a lot in the recent times with all the infographics, so that also decision makers can make use with little information, but valid information. And then we are very weak, especially to show and to showcase the use of the data in cancer control. It takes us always a long time to find out good examples on how the data have been really used in cancer control. And as it is a staging and prognostic factor meeting, it's also, I mean, the gap between developing countries or less developed settings and more developed settings is every time bigger. And it's very difficult to have good data even if the registry in low and middle income countries makes a lot of effort to have stage data, at the end you see so little information. I was looking just as an example in some data for Uruguay on colon cancer, 50% without staging data. So I think that something needs to go beyond our discussion of registries, but also enter into the clinical community to, I mean, either if the countries don't have electronic systems, or I don't know how to break a little bit this cycle of no availability of data in the primary source, which is what is in many times limiting the registry to collect the data. And how do we make a little bit more insight into clinicians in the importance, because oncologists necessarily will stage even in their head the patient to take a decision, but it is then not in the record. So I don't know how to deal with this, which is maybe a little micro, but which is affecting our possibility to collect data.
Thank you. So, you know, we have written quite a bit about it, and I don't know, Jim, do you want to talk about certain degree of frustration that we had over the years with the use of staging and prognostic factor nomenclature in the application, and the publication that you recently had to clarify the optimal use of the taxonomy. You're muted.
Sorry, I muted. Yes, I mean, I think as Mary said, we were very frustrated in how people use stage differently. They define stage differently. It's inconsistent use and inconsistent terminology. So we had a consultation process with literature review and survey, and then a meeting with all the, well, not necessarily all, but most of the stakeholders involved with staging. And we wrote a consultation paper that was published in Nature Reviews end of 2019, I think.
Yeah, December 2019, Nature Reviews Clinical Oncology.
Sorry, I've just muted myself again. I'll try and put it in the chat.
Okay, put it in the chat. And Brian O'Sullivan, you've done a lot of writing about prognosis, prognostic factors, scenario, and also the appropriate use of this information, both in clinical practice and in research.
I was going to make one comment, which probably is relevant to what you've just asked, Mary, and that was going back to Hadi's question, which Marion and Lisbeth addressed from a registry standpoint, but I was intrigued by the statement about the public advocacy for cancer control, which I think is very important. And in fact, that is another big element in the environment, which is the public awareness component and education and socioeconomic status of different jurisdictions. Leading to things like early diagnosis, dispelling myths about cancer, advocacy for cancer, and even getting over problems such as getting appropriate pain management and narcotics in to help patients at end of life. So this whole area of the patient involvement is something that has been underemphasized as well. So I'm glad you asked that question. And getting back to Mary's question to me, we have assembled all of this material in a number of different books from the UICC, the most recent of which is the UICC Cancer Staging Manual, which unfortunately I could show you a copy of it, but they're way above me, behind me here on shelves that I'd have to get a ladder out to pull down. So I have several copies of it up there I could show it, but it is a, pardon me? Yeah, that book there. So this book here is a book that A number of us, at least Jim and myself, at least, are on the editorial board for it. I'm the chief editor of it, and it is a relatively comprehensive book relative to all the different cancer sites, done in a particular format, which is supposed to be accessible and easy to read. But most importantly, it addresses all these issues that we've been talking about this morning. So there's a number of different chapters on this whole area of that we've been discussing, but also each site-specific chapter has got what we call the grids, which are these tabulations of prognostic factors according to tumor, host, and environment, and then stratified according to their relevance. Those that are required for treatment, those that are additional factors that I mentioned earlier that might be required, for example, for stratification on a clinical trial, or for some aspect of the management and administration of the treatment, and then those that are in their more developmental stage as additional factors, new promising factors that could be part of research for the next level. But starting out with the important ones, which are those that are required for treatment. And so each chapter in the book has got those, and they've also been developed in earlier versions of our prognostic factors in cancer books from the UICC as well. So they just try to put a little bit of a promotion there for those, because they are they are useful in terms of your thinking about prognostic factors.
And Susanna just put a link to the Manual of Clinical Oncology in the chat for those who are interested. We continue to do some work on the subject because those of you who are in clinical practice have one use for staging prognostic factors, and that's in decision making and communicating with the patients. People involved in cancer control have different uses for information about disease extent, stage, and prognostic factors that need to be put in cancer registries, looking at the progress in population-based cancer control, resource utilization, and other aspects. And what we're going to do in the next couple of years, really to bring different constituencies to talk about what's important to different constituencies, from the clinical to research to cancer control constituency, and looking how we can meet the needs of everybody. I think we're out of time. This was great. I want to thank my colleagues, the panelists, for very informed discussion and covering the subject as much as they could in the short period of time. And I'd like to thank the audience for joining. If you have any other questions, please put them in the chat and we can answer them individually. You can also email us. We have a staging TNM help desk at UICC, and we can connect with you. So Susanna, over to you to close, or Alessandro, I don't know whether you want to make any closing remarks.
Well, thank you very much for joining us today. I have just shared a TNM email address. If you have any questions, please feel free to email us and we'll get back to you. That's it from us for now. Thank you very much and goodbye.
Bye-bye.
Bye.
Bye.
Thank you. Goodbye.